Let's continue studying. ዛሬ ይነጋል ቢካዝ ነገ በዓል ስለሆነ ነገ ፍሪ መሆን አለብኝ። ሶ ማክሰኞ ፋይናል አለብኝ። ዮ ጋይስ ሶ ማክሰኞ ፋይናል ስላለ ዛሬ እያነበብን ነው የምንተኛው ማለት ሶ ዛሬ አንተኛም። ያ ሶ ዊ ዊል ከቨር አ ሎት ኦፍ ቶፒክስ። ፓቶሎጂ በደንብ ይነበባል and we will do a lot of questions as well. And also we will also cover pharmacology, drugs about platelet bleeding disorders ላይ ያሉ and also we will see the pathology of this. And so እግዚአብሔር ከፈቀደ we will stay to አሁን ስንት ሰዓት ነው? So now as you can see right now as you can see here, you see this? Yeah, we are 2:07 ነው። so we will stay till 10 10 ሰዓት ድረስ እንቆያለን ማለት ነው። አልተኛም ዛሬ I'm freaking crazy like አልተኛም። so let's go. Can you see my screen? Can you see it? Gosh. All right. Okay, let's continue. Myelodysplastic syndrome. All right, with fatigue dyspnea on exertion now shows these findings. Let's go look at it. I think ሙቀት እየተሰማን ነው። so let's change ልብስ ዮ እንዴት ነው? ሙቀት ምናምን አልቻልም እና ከስቻለሁ። ያ ምን በጣም ከስተናል። ምን 3 ደቂቃ ሙሉ ሳልሰራ ላብስ ሾው አለ ምን አለ ዲስፕሌይ ያለው ፋቲግ ነው። ሶ ሄሞግሎቢን ሰፊር ነው። ኤምሲቪው ኦኬ ሶ which is ኖርሞስቲክ አይደለም kind of ሜጋ ፕላስቲክ ጋር ገብቷል። ኖርሞስቲክ ከሆነ ከ80 እስከ 100 ነው። so which is ሜጋ ነው። so ሜጋሎ ፕላስቲክ ሆነ which is kind of folate deficiency ምናምን ሊያመጣበት ይችላል። so blood smear occasional blast hypogranular neutrophils pseudoplasia huge cells bone marrow show hypercellular myelodysplastic change in all three lineage. ሶስቱም ላይ hypercellular ያሳያል። occasional blast peripheral smear shows occasional blasts 2% ያሳያል። ኦኬ so this ይሄኛው ማይሎፕላስቲክ ሲንድሮም ከምን ጋር መሰላችሁ የሚሄደው ከሲኤልኤም ጋር ይሄዳል። so whenever it is chronic myeloid leukemia ጋር ይሄዳል። so chronic myeloid leukemia is when it is greater than 20%. When it is less than 22%, it is MDS. So this is, and also one of the features is dyspnea. Dyspnea means kind of, I believe this is dyspnea on exertion. So dyspnea is at the ችግር መሰለኝ We will see. Shortness of breath or labor breathing. Yeah. So bone marrow biopsy shows hypercellular marrow dysplastic, which are the most likely diagnosis. ይህን ነገር ስላሳየኝ ምናልባት እነዚህን ነበር የሚለው ፕላስቲክ አኒሚያ ሜቢ አይደለም ግን but this is the marker. Okay, acute myeloid leukemia በሚሆንበት ጊዜ አይደለም ሲ ነው የሚሆነው። The typical feature is dyspnea ነው በደንብ ያስኩት dyspnea and also this 2% ይያዛል dysplastic change in schizophrenia. So let's see. So uh, hypogranule ያ የሚል So myelodysplasia, abnormal myeloid progenitor cell leads to ineffective hematopoiesis እንትን ያደርጋል። So most often anemia, thrombocytopenia and neutropenia ይከሰታል። So when it is anemia በሚሄድበት ጊዜ more on so okay, so megaloblastic anemia እንደሚሄድ ያሳየናል ማለት ነው። And so blood cell less than በሚሆንበት ጊዜ cell neutrophil antibody test is positive. Okay, this student present with fever, fatigue, and pharyngitis and posterior cervical limb. Okay, cervical. And labs shows this. Okay, ትንሽ ነው ብዙ አይደለም። ኢንፌክሽን ላይ የሚያህል ነገር ነው አይደለም። ዲስ ዋን ኢንፌክሽን 17,000 ይደርሳል። 60% ሊምፎሳይት ኦኬ ኦኬ 60%, that's crazy. Many of which are larger and typical domicile. Okay, neutrophil antibodies also positive. So reactive CD8 T cell ያ እንደዛ ነው ያለው ቢካዝ ይሄኛውን ነበር ያያችሁት 14,000 ነው ኢንፌክሽስ 17,000 ድረስ ይደርሳል። So kind of normalization again this is reactive. So infection mononucleus cause reactive this lymphocyte atypical lymphocytes or downly cells. So typical lymphocyte. So these are like ምንድናቸው? ፖሊክሎናል ኦኬ ፖሊክሎናል ነን ማሊግናንት ሶ ሞኖክሎናል ከሆነ ማሊግናንት ነው። ኦኬ ቲሴል ሪስፖንደንት ቱ ኢቢቪ ኢንፌክትድ ቢ ሴል ኦኬ ኖት ማሊግናንሲ ሴቲስ ማሊግናንት አይደለም and not blast and also yes. Now let's go to hairy cell. So 65 recurrent infection አላቸው early satiety ይኖራቸው ሊጠግባሉ which means spleen ናቸው ነው ወደ እየደገፋቸው ያለው ማለት ነው I believe on examination massive yes noted without this ይሄኛው የላቸውም so they have spleen that's why early satiety ይኖራቸው ማለት ነው so splenomegaly without lymph without so this is በጣም low ነው so the WC is low hemoglobin is severe በጣም ትንሽ ነው ፕላትሌት ይዞ ሶ በጣም ሲቪር ነው which means there must be የሆነ ቦን ማሮ ላይ ችግር ሊኖር ይችላል ኦኬ ሊምፋዴኖፓቲ ከሆነ ማለት ነው then split peripheral blood is difficult to interpret too low WBC count but በፊኮት preparation reverse with fine appearance in hair like cytoplasmic projection so hair like አላቸው hair like projection አለ and WBC በጣም low ነው HG is also low ነው and also platelet is also በጣም low ነው so but hair like structure አላቸው typical feature ነው hair like structure the cytoplasm hair like projection if they have hair like projection the marker is this CD 103 is very important so CD 103 አላቸው so I believe C is the answer so yeah hair like H cell leukemia present with pancytopenia massive megaly and so what is say right so all right do you see my screen ኦልራይት ኤኒዌይስ ምንድን ነው የማይታየው? አሮን ጉዱ ሪሲት አይደል? So I was trying to check whether Harry Hodgkin or non-Hodgkin ቼክ ለማድረግ ያሰብኩ ነበረ። ያም ይረሳል። ማን በፈጣሪ ስም ኤቭሪቲንግ ይረሳል። ሜን ኦኬ ሄሪ ኦልራይት ናው hairy cell leukemia. So hairy cell leukemia, their typical feature is massive splenomegaly. No? So hairy cell tableau splenomegaly is very important, and usually age is so spleen and bone marrow. Okay, let's study this thing now. I will put it. Okay. I have wait a minute. And my notes. Sure. Okay, so here is a leukemia. Um, right. Okay, so let's see. I'm trying to understand. Okay, this is chronic leukemia, but እዚህ ጋር ደግሞ no, the teacher's PowerPoint is okay. ቆይ አሁን ስለ ሄሪ አውራና I'm gonna make a general higher overview video that I will share my notes, general overview notes about everything that is described. All right, yo, I describe let's say so. Okay, let's go one by one. And one እያሄድን ብንሄድ ይሻላል instead of ከምሮጥ okay now chronic leukemia yeah እዚህ ጋር አንብበናል አይደል this express እዚህ ጋር usually massive አላቸው the developing growth እዚህ ጋር and the markers are here contents እዚሁ ጋር ግን እዚሁም ቢሆን ይሻላል ሞሮ ኦርጋኒዝ ቢሆን ይሻላል ነው and multiple myeloma is kind of plasma cell ጋር ነው አይደል oh well man ልናቆም ነው ማለት ነው wait a minute, space የለንም። Okay, here space የለንም አይደለም? Alright, this is, yeah, man, like, sorry for this. ብዙ መቀጠል የምንችል አይመስለኝም። አሁን ማይ ፒሲ እንትን እያለ ስለሆነ ልዝጋውና ድጋሚ እመለሳለሁ በሌላ ሌትስ ዱ አትሊስት ስልሳውን ጥያቄውን ዝም ብለን እንስራና ከዛ በመለስ ሶ መልቲፕል ማይሎማ 75 ሰቪር ባክ ፋቲግ ሪከረንት ኒሞኒያ አለው። ብለን ብንሰራ ይሻላል ከምናገረባበት። ኒሞኒያ አለው and ኒሞኒያ አለው then back pain አለው right so back pain አለ and also hypercalcemia one of the typical feature calcium ያለው calcium is very very high hypercalcemia and maybe anemia ሊኖረው ይችላል creatine ያለው then this is very high also total protein albumin አለው urinalysis without hematuria electrophoresis level monoclonal spike and peripheral smear ሮሌክስ ይሄ በቃ ግልጽ ነው ሮሌክስ ካለው ሮሌክስ ፎርሜሽን ካለው and all of this በቃ ግልጽ ነው there is a video about this and like, wait a minute. You see this? So in this image, this guy is multiple myeloma, and you see here back pain, and this hypercalcemia, and this hemlate, all right, and Archer antibody guy, and this is monoclonal alone. You see, all of this is expressed as increased hyperplasma chromatin Russell. Right, so this is increased plasma clock phase chromatin Russell bodies. So this patient has multiple lytic disease, hypercalcemia, renal failure, anemia, hemopropenia. Bone marrow shows increased plasma cell, usually greater than often cited, with characteristics feature eccentric nucleus, clock, phase chromatin, prenuclear clearing, and possible Russell bodies, symptomatic inclusion or Dutcher bodies, nuclear inclusion. So AML, myelofibrosis, and myeloblast syndrome. So let's continue. 45 ዓመት human with history of metastatic breast cancer present with fever and fatigue WBC በጣም ትልቅ ነው which is infection አለን በላይ ነው okay with neutrophil band and metallocyte myelocyte and occasional promyelocyte platelets are normal okay leukocyte alkaline hypercalcemia ነበር አይደለም hypercalcemia so multiple myeloma so this is plasma cell okay okay Jesus Christ all right so leukocyte score is elevated okay which are the following condition for chronic okay let's see ML condition okay which one is so low in this patient. So this is the typical feature ብዬ አስባለሁ። እነዚህ ሁሉ አሉ። That's crazy neutrophil band. Every situation like every step of እንትኖች አሉ ማለት ነው። So lap is the typical እንትን ነው። So leukocyte alkaline phosphate. Phosphate. These tests usually occur on the mature neutrophils. Okay, so it doesn't occur in mature lymphocytes. So it does occur in mature lymphocyte, but as it gets to dysfunctional because of the cancer, it will become low ማለት ነው. So C is the answer. Oh man, yeah, hi, yeah, አገለባበጥኩት ማለት ነው. So አይኖርም. Okay. The patient, oh, what? No, display leukemoid reaction, extremely leukocyte due to infection, inflammation, or with high. Okay, CML typically show low score basophilia, and this definitely distinguished in the absence of Philadelphia. So toxic. And now the answer, the presence of Philadelphia distinguishes the organization from this. Okay, from chronic. Okay, what? What is this? Elevator, no, it's very high. It's very high now. This person is very high. But in CML, LAP or leukocyte alkaline alkaline phosphate, leukocyte alkaline phosphate. So leukocyte alkaline phosphate is very low. All right. So this patient has leukemoid reaction, which is extremely like extremity of due to infection, inflammation. So, but typical show like low lab low ነው and like basophilia ይኖራቸዋል ግን it is kind of rare ቢሆንም they have basophilia and also splenomegaly and translocation of 9 to 22 ይኖራቸዋል አቤል BCL cell. So አቤል BCL cell is tyrosine kinase. So tyrosine kinase inhibitors እንጠቀማለን በዴይሊ ማለት ነው። So then at some point መስራት ያቆማል. So we have to transplant bone marrow ማለት ነው. So this in CML ማለት ነው. So definitively distinguishable is this. So presence in megaly, of course, presence of basophil maybe the presence of in this patient. This is a condition from chronic. Okay, what? This is lichmoid, splenomegaly, and TDS. This definitive way, the definitive way to distinguish is absence of in lichmoid. So lichmoid reaction نملكت. So lichmoid reaction. So lichmoid reaction ላይ ምን አለ? lichmoid reaction ላይ high LAP አለ, which means dysfunctional አይደለም ማለት ነው. Okay, so high ያላቸው and extreme leukocytes white blood cells ማለት due to infection ግን this 65% is very like it's በጣም ብዙ ነው. Okay, this very high, and one of the distinguishing feature is splenomegaly ሳይሆን this the translocation of Philadelphia chromosome, the translation factor ማለት ነው. So the presence of chromosome, and here we don't have like no Philadelphia chromosome like. So lymphocytosis, clonal and reactive. All right, so a 70-year-old woman found this. Okay, this is kind of infectious active meters. No, it's normal, but typically infectious. I don't know. So on routine exam, differential shows that 70 lymphocytes. So lymphocyte basically many are known percent of lymphocyte and we can search this on Google and the only powerful alright kappa light chain okay እናውቀዋለን ይሄ ነገር kappa light chain ምናምን አለት most approximate appropriate next step ምንድን ነው so ምን ቢደረግ ጥሩ ነው so bone marrow biopsy observation with react CBC in 6 months chemotherapy with fluoroderable CT chest abdominal pelvis peripheral blood smear for smudge cell ኦኬ እነዚህ ነገሮች ኦኬ ቅድም ስመጅ ሴል ብለን ነበር አይደል where is the smudge cell ኦኬ ዲስ are የተደፈጠጡ ስመጅ ሴሎች ናቸው these are smudge cell was for what neutrophils 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 this is not neutrophil it is not a neutrophil it's a neutrophil oh you see granulocyte oh we don't have granulocyte so it's not a neutrophil it's a no neutrophil now lymphocyte this lymphocyte this smudge the smudge cell is like where is smudge yeah is it here this is hairy thing so oh is it small lymphocyte no, this is hairy cell yeah this is smoked so this is CLL man. So yeah, this is corona. So yeah, CD is co-expressed with yeah, I think. So do we need like I think this is crazy chemotherapy with fluorouracil and now this one. So starla. Okay, these ones are the highest one are B and this is T. Okay, identity crisis blank yeah, you know, but this one is kind of the highest one, and we don't have 21 as well. The 22 bone marrow biopsy እነዚህ ነገሮች ማርከር ሆኗል አይተዋል ማለት this shows marker so these are B cells እንዳለ this is B cells and also this is the marker of T cell so these are the marker of B cells and this is the marker of T cell and also kappa light chain restriction ምን ያድርጉ so bone marrow biopsy observation with repeat CBC in 6 months chemotherapy with fluorouracil CT chest abdomen and the pelvis peripheral blood smear for smudge cell okay, one of it is asymptomatic is also one of a clue, and the other clue is CD5. And I haven't digested this information, but one of the things I can guess clearly is this is, I believe, so my guess will be bone marrow biopsy. Why biopsy? Why do we need? Why this is okay? Should we give it 6 months? Maybe, because it's asymptomatic, and if it is infectious, we may know. But this guy, lymphocyte, is crazy. So the lymphocyte is very, very high. So maybe for smudge, because smudge cell is CLL, so chronic lymphocytes leukemia. So maybe, and this is above the infections level, and also these are the markers in the lymphocyte. This is a marker. So I would say, yo man, like man, ይሄን ብየው ነበረ but B ብዬ ነበር ግን I guess this alright it's okay so this is CLL flow diagnosis of course it is CLL weak light chain and CLL is often incidental in early stage like lymphocytes only the asymptomatic patient with early do not require treatment observation standard so bone marrow biopsy is not needed for diagnosis is reserved for asymptomatic or advanced this is not first line in asymptomatic patients. Yeah, this is yeah. This is not asymptomatic for the first patient, and are expected but would not change management. Of course, yeah, it could be by management to affect and the Gilson. I made a mistake, like CBC, yeah. This በስድስት months because yeah, that's good. 69 ዓመቱ ነው አመቱ ነው ማርከር ሊምፎሳይትስ ኦኬ ማርከር ሊምፎሳይት 150 ዲስ በጣም ብዙ ነው። 3 ቢሊዮን መጋል ያለው ጀነራላይዝ ፓቲም አለው ግን ኦልራይት ኦኬ ኦልራይት ሶ ዊ ሃቭ ምንድን ነው የምንይዘው ማን ኢዝ 69 ዓመቱ ነው ኦኬ ሶ ቲፒካሊ 69 ዓመቱ ነው እነዚህ ነገሮች አሉ ኢዝ ኔጌቲቭ ሶ if it was positive የሌለው ነበር it is negative and these are D cells T cells adult ነው so this is like T ነው የሚሆነው so adult T leukemia lymphoma ነው የሚሆነው so probably I don't think so this is adult T cell oh what the fuck and okay let's see okay splenomegaly lymphadenopathy oh Jesus all right so fluoride infusion yeah ኤዲማም ሊኖር ይችላል ስኪን ኖዱልስ and also peripheral biopsy peripheral smear ምን ያሳያል አንደኛ medium size lymphocytes like medium sized and prominent and this is TDT is negative አይገኝም ማለት T is negative it's negative so adult leukemia T prolims okay no okay so TPL is aggressive post-thymic T-cell neoplasm presenting with high splenomegaly and the skin involvement and serious effusion. So medium lymphocyte with prominent macula and these are the morphology. So these are strong unlike meiosis fungocytes. Meiosis fungocytes ይታያሉ እንደ where is meiosis fungocyte? Do we have meiosis fungocyte? These are like okay, the most common type of more than 90%. Okay, follicular B cell ነው ምንድን ነው? Is it B cell T cell? Because lymphocyte, I don't know. Like what the hell? Indolent. ኦኬ ፎሊኩላር ቢሲኤል ነው። እሺ ሶ ኢሚኖታይፕ strongly unlikely in mycosis fungus. So CD2 እነዚህ are strong unlike in yeah, so associated with HTLV D often has hypercalcemia floor cells be present with ስለዚህ ኢሚኖታይፕ እነዚህ አሉ ስትሮንግ ሶ ሲዲ ስትሮንግ unlike in is also negative so ማን ላይ ነው ይሄ ይሄ ሁሉ ፊውቸር ያለው who is this guy T cell what the fuck probably lymphocytic leukemia. Alright, so certain amount to present with generalized lymphadenopathy, splenomegaly, lymphatic. CBC shows 60% lymphocyte is on the range, but dried blood cell is crazy. But also 60% is not on the range, of course, because 18 እስከ 42%. ሳይክሊንግ ያ ማንትል ነው 12 18 or 11 14 ነው መልሱ 12 18 or 11 14 ከሁለቱ አንዱ ነው ማንትል ሴል ስፕሊኖሜጋሊ ያለው splenomegaly lymphadenopathy fatigue and we have CD plus 5 the Aslastin CD higher CD high source FM37 and cyclin D1 አንተ ተጫወተችብኝ ሁለተኛ አልገዛትም ምግብ እንዴ ያልበሰለ ማን ያልበሰለ እንትን ትሰጠኛለች ያልበሰለ አቮካዶ ማን እሺ በቃ ቢ ነው ኦኬ translocation of 11 14 so mantle cell lymphoma in leukemia phase these are not All right, so now dismantle. Shirazi, this Brookit. Okay, so result fusion cycle in the overexpression. Okay, yeah, Brookit Noah. So the Brookit one, Brookit lymphoma is like T 8 14 Brookit ነው so follicular lymphoma yo yo yeah the follicular one. Fact social media ገደል ይግባ እግዚአብሔርን ሶሻል ሚዲያ መጠቀም የለብኝም I was very sharp very sharp person. Jesus Christ, I lost my identity somehow. I was very sharp on my speech as well as vision and life. Now I got very distracted. Jesus Christ, very distracted. The devil played. So, Bruchid lymphoma and this, then follicular lymphoma. Yeah, then this one is T922 translocation of this is of course this is Philadelphia chromosome and LLI and translocation of 2 and 5 is AL CL or ALK. So follicular lymphoma, Burkitt lymphoma, Burkitt lymphoma ብሩክታዊት የምትባለው ልጅ በ8 ዓመቷ በ14 ዓመቷ 8ኛ ክፍል ነበረች ልክ እንደኔ። እኔ በ13 ዓመቴ ነበረ 8ኛ ክፍል የነበርኩት ሚኒስትሪ የወሰድኩት። Jesus Christ, I have to like this year is my year. You see this room, I will transform it. Like you see this room, you see everything, I will transform it. Like this year is my year. Jesus Christ. በ13 ዓመቴ ነበረ በ10 ዓመቴ በ16 ዓመቴ ነበረ ሚኒስትሪ ማትሪክ የወሰድኩት 16 ዓመቴ 12ኛ ክፍል በ17 ዓመቴ 18 ዓመቴ ነበር ዩኒቨርሲቲ የምገባው በ18 19 ዓመቴ ነበር Jesus some years some ages fall out from my enemies እግዚአብሔር ያውቃል ብቻ I will try my best to change everything so a newborn dysmorphic feature flat faces and a single palmar crease present with leukocytosis and blasto. Okay, this is crazy. 30%. Okay, CLL. Yeah. Oh, is it Down syndrome ካላቸው? Okay, LL ይቻላል. But 30% blood smear, that's CLL. Oh, that's CML. I think CML. So the baby, oh, otherwise well. Karyotype revealed trisomy, so newborn with dysmorphic feature, flat face, single palmar crease, present with leukocytosis, በዚህና 30% ብላል። The baby is otherwise well. Revealed triopsy አላቸው። So what's the most management? So what is immediate induction chemotherapy? Yeah, chemotherapy is very important. Yes, chemotherapy is very important. A ነው. What observation with spontaneous resolution expected? The fucking fuck with downspec can develop transient abnormal myelopoiesis, also called transient myeloproliferation disorder. Blasts are often megakaryoblast and may have JTA1 mutation. Spontaneous isolation occurs within first 3 months in most cases. However, this will develop acute megakaryocyte leukemia later, and immediate chemotherapy is not indicated unless life-threatening complication occur. Okay, transient abnormality myelopyosis ሊያጋጥማቸው ይችላል and occur within the first 3 months in most cases, and will develop acute megakardioblastic leukemia later. All right, all right. God damn it. Jesus Christ. So all who receive kidney transplant 6 months ago present with 5 cancer management and okay, EBV PCR is positive biopsy and lymph node shows polymorphous lymphoid infiltrate with typical B cells, EBV encoded RNA C2 and virilization is positive. So transplants 58 ዓመቱ ነው። 55 ዓመት የሮድ who received kidney transplant 6 months ago እንደዚህ ቶንሲል ማኔጅመንት አለው ትክክል። Okay, so EBV Epstein-Barr virus PCR is positive አለው lymph node shows polymorphous with typical B cell and in situ hybridization which one is running the most. Okay, so the first maybe immunosuppression. Yeah. So post-transplant lympho disorder is often driven and occur due to impaired T cell surveillance. First-line treatment is reduction of immunosuppression to allow immune recovery. So if no response, then rituximab or chemotherapy may be used. So this is high yield, always reduce immunosuppression first in PDA. All right, let's go. Chronic granulocyte. A 2-year-old boy present with recurrent skin abscess, pneumonia, and suppurative lymphadenopathy. Labs shows marked leukocytosis. Neutrophil tetrazolium slide test shows no reduction of the yellow dye to blue for Mazen in his neutrophil. So this generation is like highly involved in social media, and now they don't have their own thoughts. Like they don't have they think nothing. Everything is like يقيد them. They lost in their mind, and the very thing like every fucking action you do, they interpret it. That's crazy. Yeah, that's crazy. Which we will know. Who knows? Who knows? ግንባሯም እያደረገኝ ናት። Anyways, okay, so 2 ዓመቱ ነው። ስኪን አለው፣ ኒሞኒያ አለው፣ ይሄኛው አለው። ምንድን ነው የምፈልገው? ማርኬት እንደዚህ ይችላል። ሶ ዲስ ጋይ ሾው ኖ ሪዳክሽን ያለውን ይሄ የለም። ሂዝ ኦልደር ብራዘር ዳይድ በዚህ ችግር ሴፕሲስ። ኦልራይት ሶ ሴፕሲስ ከተባለ ዲፊሸንሲ ኦፍ ዲስ ጋይ ቢካዝ ዲስ ኢዝ ዘ ኮዝ ኦኬ። ይችኛዋ ኢዝ ቬሪ ቬሪ ኢምፖርታንት። Oh, whoa, wait a minute. I thought this is, man. Oh, no. Not the deficiency of this. No, the excess. What the hell? Okay, yeah, access in normal demo. Okay. G, result defect in pH. Oxidase failure to produce superoxide recurrent infection with catalyst positive organisms. S. aureus and Caldera, Cephalacia and Serratia in Cardia spillogenous NBT test is negative, no reduction, most common form is X-linked, and no deficiency, milder, not recurrent abscesses, aspergillus, and C5 deficiency, impaired chemotaxis, and deficiency leukocytosis, delayed separation of umbilical cord. Severe G6PD can impair oxidative burst but milder course. Newborn present with delayed separation of the umbilical cord greater than 30 days. With sign of this, CBC shows okay with predominance of mature neutrophil ያለው flow cytometry CD18 neutrophils. Okay, CD18 neutrophil is not a marker of B cell. Which one of the following child susceptible to disseminated? I don't know. I don't know. I'm not sure. I'm not sure about this. Okay, this is our skin. It's new to me. This is new information. ይህን ነገር መለየት ችያለሁ. But this information is new to me, so we will see this case. Do we have a paper? If I find a good paper, I will read it. All right, we have addition problem, addition, leukocyte addition deficiency. Okay, do we have good ideas here? Hello, Zion Ball. What's Kaza need? What the leukocyte addition deficiency? Okay, so leukocyte deficiency is a disorder involving this and this. Okay, to migrate. All right, cool. All right, so ቅናሽ ነው ማለት ነው እንደዛ ከሆነ what is the case ታዲያ? Is this no? Oh, okay, ብዙ ነው ግን okay, let's see. Um, and reviews the role of if I am average, I won't have a chance in this life. Like literally, if I am average man, average, just average person in any action I do, I would not have a chance in this world. Like the world is an average, but like my school, I went to average school. The teachers were average. The typical teachers, they They share instead of teaching. They talk shit about the government, the current situations. They try to politicize everything. Po, okay, man, like everything. And my friends were average. My dreams were average. I dreamed of average dreams, common dreams, common dreams, common dreams, and I will end up. It's literally that's my past. I will end up average person. I will graduate and somewhere I will work somewhere else, and that's also an average job because my grades are on average of the class, just to pass. Because I've been an average person, so I have to break that out. Anyways, this activity describes the evaluation, management, and efficiency and role in professional team. Okay, cool. So what is this objective? What the fuck is going on? Okay, ምንድን ነው የሚሰጠኝ እዚህ ጋር ሳነበው ኢቲዮሎጂ እንማራለን፣ ፓቶፊዚዮሎጂ እንማራለን። ኦኬ፣ ይህን እናያለን፣ ኢንቨስቲጌት እናደርጋለን። እሺ አሁን ምንም ልመልከት። ኢቲዮሎጂ አይ ዶንት ፋኪንግ ኬር አባውት ኢቲዮሎጂ በት ዘ ኮዝ ኢዝ ቬሪ ኢምፖርታንት። ሶ ዋት ኢዝ ኮዝ? ኦኬ ዲፊሸንሲ is a defect cellular adhesion molecule resulting in okay this is cool clinical syndrome አለው what ኮምባይን ሁለቱንም ይይዛል እሺ ምንድን ነው ሜጀር ኢሚኖሎጂ the thought process ከሁሉም በላይ ደግሞ this thought process is very ill average ill full የሆነ thought process ነው ያለኝ that is ill man we have to ማሸነፍ አለብን so their inability to form okay cool passes we know pass okay neutrophils ah did I hear you neutrophil ብለህ this is leukocyte okay of course leukocytes include neutrophils but we don't need to use do we need this cells and characters in ability leukocytes to migrate to the site invasion kill microbes this activity all right so the first people are the migrators the first warriors neutrophils they form pus and do they need B and T cells? We will see. So the effect is the effect of cellular lesion molecules in clinical symptoms. Okay, it says combined immunodeficiency disorder. There is inability to form pus. There is deficiency of various glycoproteins, including these guys, marking this. And glycoprotein, this is a number, and leukocyte cannot migrate to infection sites to kill invading microbes due to mutations in CDDs. Okay, CD. Antigen molecule deficiency results are inflammatory response in eventually recurrent bacterial infection. Cool. Okay, this is just general intro. Now let's talk about the pathophysiology difference of the following integrins. Okay, this guy cause immunological clinical abnormalities in this adhesion deficiency. These proteins, they are present at lymphocyte, granulocyte, monocyte. Okay, so this LFM, okay. If I am an average person, I won't have a chance. Why would I live an average life? Why don't I end it here? Like an average life, what impact does it have? Like ምንድን ነው ሚዛን የሚደፋው ህይወት if it is average it's just የተኖረ ህይወት what is it? What should I do to be not an average person? What should I do? I have to be like alright so and comment this alpha chain dominance I hear the same news the same social media the same different house that's crazy so the effect in a beta 70 is accountable for this decrease okay and is not affected cool also good is also the lesion is on okay nutrient submission studied okay now deficiency integrin this cause immunological seeing this deficiency in this protein function as addition molecule they are present on this and Okay, and here we go. Half chain and distinct alpha chain denominated Mach 1 molecules. Okay, this protein function acceleration molecule they are present in lymphocyte እነዚህ ነገሮች ላይ አሉ but እነዚህ ደግሞ these are the ላክ አይደለም የተባለው አላቸው ማለት ነው። ኦኬ እነዚህ ቤታ ሰሉት accountable for decreased expression of የነዚህ this alpha expressions. Okay, not affected the lesion or chromosomes. Unless the etiology ደግሞ need. Okay, we know this. Alright, okay, ምን አገባኝ? ኦኬ ቢከሰት ነው አለኝ። እሺ ለሪቪው ምንድን ነው የሚያሳየኝ አለ። ኦኬ ዊዝ ሪካንት ኢንፌክሽን አላቸው እና እነዚህ አርምስ ሁለቱ አላቸው። እነዚህ ቤታ ሰዩኒት ነው ለሁለቱ ደግሞ ኢፌክት እንደዚህ ሞርታሊቲ በሁለት ህፃን እያሉ ምናምን ይሞታሉ። 15% ነው። ኤክስፕሬሲንግ ኒውትሮፊልስ ኦልራይት ፓቶፊዚዮሎጂን አይተናል። ፓቶፊዚዮሎጂ ኦኬ what the hell okay alpha beta አለኝ then also like protein አለኝ what is the connection like I get the connection but what the fuck is going on okay these are integrins አለኝ these groups cause the disease አለኝ በሌላ አባባል this is they're the cause አለኝ okay cool also they are integrins of course they are proteins who the hell I don't fucking care okay then what alright እዚህ ጋር አለ ሞኖሳይትስ ግራኑሳይትስ ስላሉ cool and then this is also ምንድነው ይሄ ራሱ ኢንተግሪን ነው አይደለም and this guy this is the integrin and this glycoprotein have beta chains but have distinct alpha chain denominated M1 alright this Y and this guy cool these integrins and glycoprotein እነዚህ they have beta and alpha chains and the alpha chains denominated by M1 and L1 X1 okay who cares affecting this beta segment is accountable for decreased expression of this guy this integrin okay cool relation okay triopsy maybe ከእንትን ጋር ሊገናኝ ይችላል ከትራይዞሚ ጋር ከዳውን ሲንድሮም ጋር maybe so let's see strain physical examination recurrent bacteria ምናምን አለ ኬሞቴራፒ particularly okay cool then ከዛ በኋላ እዚህ ጋር ምን አመጣው beginning ኒውትሮፊል ኒዮን ፔሪድ አለች ከዛ ኒዮን ያገኘበት ምናምን ይታያል Training individual not for abscess. Okay, individual with that do not form abscess because they can migrate to the site of infection. Okay, lad include characterized lad 2, lad 3, lad banana common anatomy. Okay, cool. Absence of pus formation. Okay, then bronchitis ምናምን እዚህ ጋር በሌላ በባልኛ ቱበርኩሎሲስ መተንፈሻን ነው የሚዘጋው እዚህ እንዳለ ከመተንፈሻ ጋር የተገናኙ ናቸው። ከዛ ስኪንም ጋር ይገናኛል እዚች ጋር ኮርድ ከፋላነትች ጋር ይገናኛል ስትሬፕቶኮከስ አውረስ አብሰንስ ምናምን ይመጣል ደምና ብሊዲንግ ኮምፕሌሽን and this case evaluation so the evaluation is ቀደምችን አይተናት የለ okay now quantitative serum hemoglobin አለ antibody activities okay this thymus toxin polio IgG this ሬቢላ አንቲቦዲ IgG ምናምን ራይት ፋጎሳይቲክ ፈንክሽን ኦኬ እነዚህ ይሰራሉ ኢንቨስቲጌሽኖቹ ላይ እነዚህ ብለድ ኬሚስትሪ ቸስት ኤክስሬይ በደንብ መሰራት አለበት። ከእንትን ጋር አገናኝተን አውርተናል። ስለ ትሪትመንት የሚልገው ምንድን ነው? ኬሞቴራፒ የለውም እዚህ ጋር ኬሞቴራፒ ያስፈልጋል። ምንም ነው ኬሞቴራፒ ኤች ሴት አለ ሪኮሚናንት ይሄኛው አለ ሌስ ሪኮሚናንት ፋክተር ሌስ ባክ ሞስት ኦኬ ዲስ ያ ስኪን አብሰስ ስኪን አብሰስ የለም ብሎ ነበር አይደለም? ስኪን አብሰስ አለ አብዶሚናል አብሰስ ነው የለም። ኦኬ ቺዳኪ ሲንድሮም ዮ ይሄ ነገር ባለፈው ሴሚስተር አይቼዋለሁ ግን ቢካዝ አይ አም አቨሬጅ ኤንድ ዘ ቲቸር ኦልሶ ቲንክ አስ አይ አም አን አቨሬጅ አይ አክት አስ ኢፍ አይ አም አቨሬጅ ግን ምንም ተአምር የለውም። ምንም ተአምር የለውም። የሰው ልጅ ነው የሰራው። እኔ ደግሞ የሰው ልጅ ነኝ። በዓለማችን በጣም ጂኒስ የሚባለው የዓለማችን ቁንጮ ልዩነቱ ከኔ ጋር ጄኔቲካሊ ልዩነት የለውም። ኢፍ አይ ሃቭ ጄኔቲክ ዲፍረንስ ከሱ ጋር አናዘር ክሪቸር ነው የሚሆነው። ዊ ዶንት ሃቭ ጄኔቲካል ዲፍረንስ ሂ ኢዝ ሂውማን ቢንግ አም ሂውማን ቢንግ ዜር አር ቫሪዬሽንስ ትሬትስ ጂን ሌቭል ኦፍ ኮርስ ጂን ሰውን ይለያያል ግን ሂ ኢዝ ሂውማን አም ሂውማን ስ ቤዚክ ቲንግ ኤንድ ኤቭሪዋን ኤልስ በት አም አቨሬጅ ጂሰስ ክራይስት ኦኬ ናው አልቤኒዝም አለ ሶ ኢንፌክሽን ኢዚ ብሩሲንግ አለው ፋውንድ ኦኬ ጃንት ኦልራይት ሳይቶፕላዝሚክ ኒትሮፊል ፔሪፈራልስ ሚልም አለ ሂ ዲቨሎፕ ራፒድሊ ፕሮግሬሲቭ ፊቨር ጃንዲስም አለት ሄፓቶስፕሊኖሜጋሊም ይታያል። ሶ ዊዝ ፓንሴቲፔኒያ ማለት ነው። ሶ ሎው ነምበር ኦፍ እሺ አሁን ምንድን ነው የምንፈልገው? ጃን ዘፈሪንግ ኢዝ ኢንተሪንግ ሀብ ነው ብሎ ይህን ነገር አላነበብኩትም። ሜቢ አንብቤዋለሁ ኦር ግን ላስት ሴምስተር ይህን ነገር ስንማሩት እዚህ አልተማርኩም። ሜቢ ተምረን ይሆናል አይ ዶንት ሪሜምበር ዲስ በት አይ ካን ሪድ ኢት ናው ዩ ሲ ዲስ ፋኪንግ ኮድ ቡክ I completed this. Now I can read this. The beauty of internet, you can read it. Look at this. I have the whole information ማለት ነው። መረጃ በመሰብሰብ አይደለም አዋቂ ምናምን የሚባሉት ከሄደ አስተማሪዎች they fucking care like okay cool ምንድን ነው የምፈልገው እኔ ኦልራይት የምንሰጠኝ ምንድን ነው ዲስ እሺ ዲስክራይብ አውቶ ፊዚዮሎጂ ኦኬ ሰመራይዝ ምናምን ኦኬ ሌትስ ኢንትሮዲውስ አውቶዞማል ሪሰሲቭ ዲስኦርደር ካራክተራይዝድ ባይ ኢዚ ብሩዚንግ ምናምን ኦክሉዝ አልቤኒዝም አሪካን ፓይሎነስ ዲፌክቲዝም ኦኬ okay this is what the fuck is this and aspirogenic Now this is okay. This is the important thing. What was that texture? I don't have to be cool. Okay, what is the part of physiology? All right, what is the part of physiology? Okay, diagnosis, prognosis. All right, let's go. ምንድን ነው ያነበብኩት? There is a defect in the gene, and the gene is LYST. What the hell is LYST? Lysosomal. What? Lysosomal. Alright, so why lysosomal? እግዚአብሔር ይስጣት። ሁለተኛ አልሄድም እነሱ ጋር። What the hell? ሽንኩርት what the hell? ዮ እዚህም ላይ ይታያል። ጂሰስ አንዴ አስቴዮሳይት ላይ ይታያል። ዮ አንተ ናቹራል ኪል ሴለር ላይ የሚታየው oh today is all right. This guy, Gate. What is Gate? Cytoplasmic granules, of course. Yeah, this is Wilson. Oh, Jack Tuna. Yeah, میتبین so Lander and Sale. I believe this is the answer. But is it? I don't think Reed Strandberg Sale ያለው but Brayburg Ground እዚህ ነው ያለው. So B is the answer. Yeah, አገኘሁት ማለት ነው. Yeah. This is kind of tennis like tennis እንትን መጫወቻ ነው የሚመስለው. የቴኒስ እንትን የሚመስል ማይክሮስኮፕ you see? Yeah, histiocytosis. አይ ዶንት ብሊቭ ይሄን ነገር ያነበብኩት አላውቀውም። ይሄ ነገር ግን እስኪ ለሚ ትራይ ቱ ሃቭ ጉድ ገስ ፍለሽንግ ካለ ሎው ኦኬ ዲያሪያ ሜቢ ኦኬ ቢሲአር አቤል ሊሆን ይችላል በት አዎ ዲስ አይ ዶንት ብሊቭ ዲስ ሃቭ እንደዚህ አይነት ፊቸሮች ያሉት ሶ hard to say because this one, let's say this. Alright, so this is channel. So So, Schwann Diamond syndrome. Skeletal genetic testing showing mutation, SVDS gene, and then what's the most serious long-term complications. So maybe this is the case when you don't know. All right, all right. Maybe biopsy. Okay. Oh, you. ጂሰስ ሁለተኛ አልሄድም እነሱ ጋር። እሺ እዚህ ጋር እናቁም። ኦልራይት ሶ እዚህ ጋር እናቁም። አክቹዋሊ ካሰብኩት በላይ ነው ጊዜ ፈጀው። ሶ ሌትስ ዋች አ ቪዲዮ። ሌትስ ኤንድ ኢት ሂር። ከዛ ሌትስ ዋች ቪዲዮስ። Okay, now let's share the screen. ከዛ alright, so you see the video? Alright, so I'm gonna touch the button. ከዛ we will see.
Let's continue our journey through the lymphoid neoplasms. Cancers derived from the B and T cell lineage. In our last sketch, we met the... In our last few sketches, we went over the myeloid neoplasms, cancers that derive from myeloid progenitor cells. These are stem cells in the bone marrow that give rise to the myeloid cell lineage, which includes red blood cells, megakaryocytes, which make platelets, monocytes, and granulocytes, such as neutrophils, eosinophils, and basophils. Well, forget it. Clear your mind, because we're moving on to the lymphoid cell line. That means B cells and T cells, friends. This sketch is the first in our series on the lymphoid neoplasms, and we're starting with acute and chronic lymphoid leukemia. Now, I know that you're thinking, hey, whoa there. That says leukemia and lymphoma. There's something you're not telling me here. I thought we trusted each other. I want my key back. Okay. First of all, you're overreacting. And you know what? I feel like we need to set some kind of boundaries in our relationship here. This is getting a little too serious for me. Now, about that whole leukemia lymphoma thing. You're right. Turns out, the B and T cell neoplasms we're about to cover can present both as a leukemia or as a lymphoma. These are just general terms for where in the body these neoplastic B and T cells are setting up shop. In the case of a lymphoid leukemia, neoplastic lymphoid cells take over the bone marrow and cause cancer cells to leak out into the peripheral circulation. This is represented by the royal banner, which shows the cancer crab in the marrow sending malignant cells into the blood. Contrast this with lymphoma, which at Sketchy we symbolize with a chessboard overloaded with chess pieces. The board represents a lymph node, and that accumulation of white T cell knights and B cell archers is meant to evoke an image of abnormally proliferating lymphocytes in that area. You see, in the case of lymphoma, neoplastic lymphoid cells form a tumor in a lymphoid organ outside of the bone marrow, such as the lymph nodes and spleen. Unfortunately, it gets even more complicated, because leukemias can present in the lymph nodes and look like lymphoma, while lymphomas can take over the bone marrow and present like leukemias. So, by the power vested in me, I officially give you permission to stop worrying about whether it's technically a leukemia or a lymphoma. I'll get back to this definition a little later on. What's most important for you to know is not where the cell came from, but what kind of cell it is. Just like in the myeloid leukemia sketch, we'll be dividing the lymphoid neoplasms into both acute and chronic forms. Starting with acute. Acute lymphoblastic leukemia lymphoma, which we'll shorten to ALL, is going to be illustrated out in the courtyard of the castle. Think of these children as immature lymphoid cells, honing their skills before they join the ranks of the leukocyte army. Recall that the lymphoid lineage includes B cells, represented by an antibody archer, and T cells, embodied by the knight in training with a T-shaped sword. The fact that they're all kids is important. This is acute lymphoblastic leukemia lymphoma, not lymphocytic. That's right, we are not making mature lymphocytes here. ALL is caused by a somatic mutation in a B cell or T cell precursor. Differentiation halts at an immature lymphoblast stage, before these cells start proliferating out of control. These fledgling knights are also here to remind you that ALL is the most common cancer in children, with a peak incidence between 2 to 5 years of age. Then here's a little 3-year-old. Still too young to train, but cheers on his comrades nonetheless. While the majority of ALL cases with a 10 to 20-fold increase in risk, 1 to 3% of ALL cases, in fact, are attributable to Down syndrome, symbolized here by the downtown label marking the planned location for the new Winterfell city center. As you might remember from our last sketch, Down syndrome also increases the risk of acute myeloid leukemia, or AML. Alright, there are 2 categories of ALL that we're going to cover, the B cell variety and the T cell variety. See that bone quiver worn by the fledgling B cell archer? Precursor B cells are derived from and begin to mature in the bone marrow. So, this is where a mutation occurs in a pre-B cell to cause B cell acute lymphoblastic leukemia, or B cell ALL. B cell ALL is actually the most common form of ALL, making up about 80% of cases. T cells are also derived from the marrow, but they mature in the thymus. It's where they train, if you will. So, in this sketch, T cell training is occurring in the thyme garden. That's time for thymus. It's here, in the thymus, that a mutation occurs in a pre-T cell to cause T cell acute lymphoblastic leukemia, or T cell ALL. T cell ALL is less common than B cell ALL, and accounts for around 15 to 17% of cases. Also, T cell ALL usually occurs in male teenagers between the ages of 15 and 20, so notice that we've made this precursor white knight a strapping young teenager. Regardless of whether the neoplasm results from a mutated B cell precursor in the marrow, or a mutated T cell precursor in the thymus, you need to see a specific cell type if you're going to make the diagnosis, and that's lymphoblasts. Lymphoblasts are one of the earliest stages of lymphocyte development. And in a normal, healthy individual, you should not see these things floating around outside of the marrow. Let's emphasize that blast suffix at the front gate, where the enemy seems to have launched a surprise blast attack. So, we have a blast. Let's say we found one on a peripheral blood smear. Blasts out in the periphery? Not cool. But how do we know it's a blast of lymphoid origin, and not myeloid? Well, for starters, they look a little different with a right Giemsa stain. Like myeloblasts, lymphoblasts are often large with big nuclei, but this time the chromatin is coarse and clumped and the cytoplasm is scant. Pretty much looks like all nucleus. We've depicted this big purple nucleus on the shield there, but this isn't good enough. In reality, lymphoblasts can be small or large and have more or less cytoplasm. What else can we look for? I know. No our rods this time, that's for sure. Remember those from the myeloid sketch? Our rods are for granulocyte precursors only. And look at all that granulation. That's also indicative of a granulocyte precursor, not a lymphoid cell. I'm still not convinced though. Another helpful way to distinguish lymphoblasts from myeloblasts is to look for the presence of glycogen in the cytoplasm, which causes the lymphoblast to stain positive for periodic acid Schiff. PAS stain is represented by the frisbee. Think of passing a PAS frisbee. Lymphoblasts will also be positive for terminal deoxynucleotidyltransferase, or TDT, which is present in all immature lymphocytes. Myeloblasts, on the other hand, are TDT negative. TDT actually plays a role in antibody formation. It's responsible for adding nucleotides to the V, D, and J regions of the antibody gene. VDJ recombination occurs in developing lymphocytes and is responsible for creating the diverse array of antibodies and T-cell receptors that are crucial for the function of the immune system. Okay, so you can differentiate a lymphoblast from a myeloblast. Whoop-de-doo. Let's focus now on we need to look at the cluster of differentiation molecules, commonly known as the CD numbers. Here's a super easy way to distinguish between the two. Basically, any CD number illustrated on the ground next to the T-cell knight in training. Recall that mature T cells are either CD4 or CD8 positive. Well, to display CD2, CD3, CD5, and CD7. 2, 3, 4, 5, 7, 8 are up on the archery target. That's CD10, CD19, and CD20. Gotta get that 20-point bullseye. Alright, now that you know whether it's a B-cell lymphoblast or T-cell lymphoblast sneaking around in your patient, there's one more question you need to ask. Where did it come from? In other words, is it an acute lymphoblastic leukemia or lymphoma? Yeah, I'm bringing that up again. But I'm going to keep the definition simple. If blasts are found proliferating and taking over the bone marrow, you call it a leukemia. And technically, when I say taking over the bone marrow, I mean that blast forms take up more than 25% of the marrow. Notice the subtle 25 design we've incorporated into that gate. It doesn't matter if these are T lymphoblasts or B lymphoblasts. If 25% of the marrow is affected, you can officially call it a leukemia. The B cell type particularly likes to present this way, which makes sense because this is where B cells are born. In that case, you'd call it an acute B cell lymphoblastic leukemia. We've put blasts inside and outside the gate to remind you that blast forms are leaking out into the circulation, where they're usually first noticed on a blood smear before a bone marrow biopsy is obtained for confirmation. When should I call it a lymphoma instead of a leukemia? Well, these neoplastic B and T cell lymphoblasts like to travel to various lymphoid organs throughout the body. In fact, they particularly like to form masses in the lymph nodes and thymus. But just because you find a mass doesn't mean it's a lymphoma per se. It all goes back to the marrow. Regardless of whether these form a peripheral mass, if you have over 25% marrow involvement, call it a leukemia. Strictly speaking, if you want to call it a lymphoma, this means that there are less than 25% blasts in the marrow, along with a mass lesion forming in the periphery somewhere. It turns out that the T cell type particularly likes to present this way, often as a mass in the thymus and normal marrow. In this case, we call it an acute T lymphoblastic lymphoma. A mediastinal mass makes sense because this is where T cells go to mature. So why not throw a temper tantrum right inside the thymus while you're at it? So remember to look for that large anterior mediastinal mass, just like the one we placed on the practice dummy being used by the T cell knights in training. T lymphoblasts also like to form masses in the lymph nodes, especially in the cervical, supraclavicular, and axillary regions. When it's a thymus mass, watch out, because other structures in the mediastinum can get compressed, resulting in superior vena cava syndrome, respiratory symptoms such as stridor and dyspnea if the trachea is involved, and dysphagia from esophageal compression. Remember though, mass or not, with lymphoblastic leukemia lymphoma, if there's 25% bone marrow invasion, it's leukemia time. Speaking of, let's talk about how the leukemic version presents. First, keep in mind that the acute leukemias have an abrupt onset. You know, being acute and all. Now, as the bone marrow gets filled with lymphoblasts, this doesn't leave any room for the production of mature lymphoid or myeloid cells. So patients with acute lymphoblastic leukemia can present with anemia, thrombocytopenia, and neutropenia. To simplify this, we've included our symbol for pancytopenia, an empty pan next to the royal cook who's tired of serving these ravenous and ungrateful kids. Clinically, patients usually present with fatigue due to the anemia, easy bruising or bleeding due to the thrombocytopenia, and fever, which can be due to infection in the setting of neutropenia or just due to the leukemia itself. Keep in mind that in acute lymphoblastic leukemia, blasts are starting to flood the peripheral circulation as well, causing a high white blood cell count on labs, leukocytosis in other words, represented by the excess of white doves. These lymphoblasts are, of course, non-functional, and the patient truly has a functional pancytopenia. Don't be tricked by all those blasts. Like we mentioned earlier, lymphoblasts like to go everywhere lymph goes. This means leukemic cells can infiltrate the lymph nodes, liver, and spleen, causing generalized lymphadenopathy and hepatosplenomegaly. This is represented here by the lymph node ornaments, hepatic oat bag, and splenic saddle. Due to the expanding marrow in the bone, as well as infiltration of the periosteum, acute lymphoblastic leukemia can also cause bone pain and tenderness. So, never stand behind a horse. Everyone knows that. Like other cancers, leukemic cells can also metastasize to distant organs throughout the body. Two of its favorite places are the central nervous system and the testicles. Meningeal involvement of acute lymphoblastic leukemia can cause headaches, while metastasis to the testicles will produce a testicular mass. Treatment is with chemotherapy, and in some cases bone marrow transplant. Fortunately, the prognosis for children is excellent. Let's talk about one form of adult-onset lymphoid leukemia that has a unique pathogenesis. It's called adult T-cell leukemia, and it occurs in the 6th decade of life, as depicted by the wise old knight up on the horse there. Adult T-cell leukemia is actually the result of a viral infection, hence the viral capsid-shaped helmet. The culprit here is the retrovirus human T lymphotropic virus type 1, abbreviated HTLV1. To remind you that this virus likes T cells specifically, we've made the opening to the helmet T-shape. This form of leukemia is most common in areas where the virus is endemic, such as southern Japan. You can think of HTLV1 as the reverse of HIV, since infection with HTLV1 results in uncontrolled proliferation of mature CD4 helper T cells. At Sketchy, helper T cells are symbolized by helper squires. Adult T-cell leukemia will be positive for the CD4 marker and negative for TDT, since these malignant cells are mature and not lymphoblasts. TDT is for lymphoblasts only. Adult T-cell leukemia presents in a similar fashion to acute lymphoblastic leukemia, with an elevated white blood cell count characteristic of all that T-cell proliferation, and cytopenias of the other cell lines, resulting in normocytic anemia, thrombocytopenia, and neutropenia. Generalized lymphadenopathy and hepatosplenomegaly can also result from infiltration of those organs by leukemic cells. Here's the thing though, even though there are tons and tons of CD4 helper T cells floating around, very few of them are actually functional, resulting in a functionally immunocompromised state. Therefore, despite HTLV1 being like a reverse HIV, the clinical result is actually the same, since affected patients are at risk for opportunistic infections just like patients with HIV and AIDS. Adult T-cell leukemia is also notorious for infiltrating the skin, resulting in skin lesions that are similar to those seen in cutaneous T-cell lymphoma, also called mycosis fungoides, with itchy red plaques and papules that resemble fungal infections appearing all over the body. Check out our non-Hodgkin lymphoma sketch for more details on mycosis fungoides. Just remember that this old white knight has accumulated some pretty extensive scarring over the years, though it's the scars you can't see that still haunt him. No, he still has all his man bits. I meant emotional. Last little fact about this weird adult T-cell leukemia thing. It likes to infiltrate the bones, resulting in hypercalcemia from the lytic bone lesions. Yes, nothing a little hypercalcemic milk can't fix. The pre-battle drink of champions. It's like taking a swig of sweet, sweet nectar from the teat of Nike herself. Treatment of adult T-cell leukemia is with chemotherapy. Unfortunately, antiretrovirals don't work against HTLV1. Despite aggressive treatment, prognosis for patients with this type of leukemia is poor. All right, that's it for the acute lymphoid leukemias and lymphomas. Let's focus on the chronic version now, which includes both chronic lymphocytic leukemia and hairy cell leukemia. We'll start with the more common of the two, chronic lymphocytic leukemia, or CLL. First of all, notice that we're calling this a lymphocytic leukemia, not lymphoblastic. Yep, we've moved beyond the blast phase. CLL is characterized by the abnormal proliferation of mature lymphocytes, specifically B lymphocytes, as depicted by the assembly of mature B-cell archers on the tapestry. As we discussed, B cells are derived from and begin to mature in the bone marrow. So, yet again, we've got a bone marrow problem. That's why the border of the tapestry is subtly bone-shaped. And you know what? It's time to draw in the king himself. Here to remind you that CLL ain't for kiddies. CLL occurs in older adults, primarily over the age of 60. And it's the most common cause of leukemia in the Western world. Let that chronically old clock up there, our recurring symbol for chronic disease, remind you that this whole process follows an indolent course, with a slow, progressive accumulation of mature but functionally abnormal B cells in the bone marrow and peripheral circulation. The prophecy of the tapestry was correct. Mature B cells, an army of bone marrow invasion from the north. Hold the door. It all makes sense now. The pathogenesis of CLL involves a B cell at some intermediate stage between pre-B cell and mature B cell. This precursor gains a few mutations, and before you know it, the bone marrow becomes a monoclonal B cell producing factory. Yep, these cells are just a bunch of clones at first. A slowly encroaching clone of army-mutated B cells, with mature morphologic features. Over time, more and more mutations start to accumulate, and the disease becomes much more aggressive and resistant to treatment. It's thought that increased tumor cell survival, not just increased cell proliferation, plays a big role here as well. It's been shown that CLL cells have high levels of BCL2, a protein that inhibits apoptosis and prolongs cell survival. Scary thought, right? These mutant B cells are like undead, immortal zombies. Though, in reality, cell proliferation and survival rates vary significantly between patients. Nevertheless, to symbolize upregulated BCL2, we have Sean here, holding a BCL2 bracelet, sent along with the message in order to prove the sender's identity. Eventually, the bone marrow of a patient with CLL will become almost completely replaced by neoplastic B cells. When you take that bone marrow sample, remember that these are mature B cells, so expect only a small portion of them to be blasts, usually less than 10%. It should come as no surprise that CLL cells express the usual B cell markers, usually some kind of combination of CD19, CD20, and CD23, with CD21 and CD24 less commonly expressed. To convey the idea of CD19 and higher, we have the king of Whitwakers himself, raised above the rest of his army, brandishing the number 19. Here's a weird one though. CLL cells can also express CD5, which is usually a T cell marker. What? These mutant cells are really trying to trick you into thinking they're mature, and they can even express some surface immunoglobulin chains, which, under normal circumstances, would have been part of the B cell receptor complex. Alright, all this talk about bone marrow. What's happening in the periphery? Around 5 to 10% of patients with CLL present with the usual constitutional symptoms, such as fevers, weight loss, night sweats, and fatigue. Remember our tired chef out there? CLL has such an indolent course, however, that most patients feel completely fine at presentation and report no symptoms. They're in your office, just getting some routine blood labs. But then you notice something on their lab results, a high white count, mostly B cells, in fact. Usually, the threshold to look out for is a B lymphocyte count over 5,000 cells per microliter. But patients can have counts that are much greater, sometimes over 100,000. Take a look at the peripheral blood smear. You should see lots of small but mature appearing B cells. Another classic finding is the presence of so-called smudge cells, fragile tumor cells that collapse on preparation of the peripheral blood smear. Now, I've said it before, and I'll say it again. Leukemias like to act like lymphomas. Lymphomas like to act like leukemias. It's just a mishmash of lymphs and emias and omas. In simple terms, all this means is that CLL cells aren't just in the marrow and blood. They like to head to the lymph nodes too. A majority of patients, in fact, will present with lymphadenopathy on physical examination. And just like we saw in ALL, hepatomegaly and splenomegaly are frequent findings as well, caused by CLL cells taking over lymphoid tissue throughout the body. CLL can even present as a lymph node tumor, a lymphoma in other words, depicted by our recurring symbol for lymph node involvement, a chessboard loaded with B-cell archers. This special type of lymphoma is called small lymphocytic lymphoma, or SLL. Small just means that these lymphocytes are mature. On histology, affected lymph nodes will show sheets of small B cells, as depicted by the small chess pieces taking over the board. SLL is a pretty uncommon lymphoma, so don't lose too much sleep over it. Just remember that CLL, a leukemia, can sometimes present as SLL, a lymphoma. Regardless of where the initial tumor cells are found, however, just keep in mind the distinctive morphological and molecular characteristics of chronic leukemia cells. That's how you'll make the diagnosis. Now, even though we have all these mature B cells running around the body, don't expect them to act normally. Not only are these mutant leukemic cells non-functional, they suppress the function of the normal B cells still present in the body. See how that mutant B cell is taking down that normal one? Some kind of outstretched death hug. Well, notice that all his antibody arrows are scattered to the ground. Inhibition of B cell function leads to decreased production of immunoglobulins, and therefore low levels of immunoglobulin in the blood. This is called hypogammaglobulinemia. Usually all three immunoglobulin classes, IgA, IgG, IgM, are decreased, and this predisposes the patient to some major bacterial infections. So watch out. Paradoxically, these remaining functional B cells can start producing autoantibodies too. Gah! These autoantibodies can lead to cytopenias, most often immune-mediated anemia and thrombocytopenia. So we've brought in the royal hors d'oeuvres, with little antibody toothpicks symbolizing autoimmune destruction of RBCs and platelets. The empty pan is meant to remind you of pancytopenia. And if you put the whole picture together, it's easy to see why. You might have autoantibodies attacking RBCs and platelets. The enlarged spleen can sequester even more RBCs and platelets, and when enough of the bone marrow is taken over by those mutated CLL cells, all the cell lines go down, just like in the acute leukemias. Remember, it's not technically a pancytopenia, as that white count can be sky high, but don't let those non-functional CLL cells fool you. If enough of the marrow is taken over, all the normal functional cells in the body will drop off. Alright, overall, the course and prognosis of CLL can be variable. Many patients will live for more than 10 years after being diagnosed. Though, as time passes, CLL can transform into more aggressive tumors such as prolymphocytic leukemia or diffuse large B-cell lymphoma, both of which decrease survival considerably. Okay, time to finish up the sketch with our last chronic lymphoid leukemia, the aptly named hairy cell leukemia. Hairy cell leukemia is a chronic B-cell neoplasm that occurs predominantly in middle-aged men. So we've hung another tapestry on the wall, this time depicting a middle-aged hunter with a B-cell bow. Hairy cell leukemia gets its name because the neoplastic cells have characteristic fine hair-like cytoplasmic projections. Akin to bear fur, maybe? Just hang with me here. These hairy cells also stain positively for tartrate-resistant acid phosphatase, abbreviated TRAP. There you go. A bear trap. See? I knew you'd like that one. Hairy cell leukemia likes to infiltrate the reticuloendothelial system, causing characteristic massive splenomegaly, which may cross the midline or extend into the left lower quadrant. I mean, just look at the size of that spleen-shaped sac. Fit a whole bear in there. As the hairy cells fill up the bone marrow, they cause fibrosis and failure of the bone marrow, leading to pancytopenia. So, we've included the fibrotic bone tree, along with our recurring pancytopenia pan symbol. Obviously, the bear took the bait. Due to extensive fibrosis, bone marrow biopsy may not return any contents. This is called a dry tap, and is symbolized here by the empty bone cup. Bears just can't resist an icy cold beverage. Works every time. Fortunately, hairy cell leukemia is responsive to chemotherapy, and prognosis is generally good. The treatment of choice is usually a purine analog, such as cladribine or pentostatin. Just imagine our caveman from Sketchy Farm clad in bear fur. That's clad for cladribine. Phew! That sketch was extensive. Nothing a quick summary can't fix. Lymphoid neoplasms are B and T cell cancers. Acute is out in the courtyard, while chronic is up in the castle. B-cell acute lymphoid leukemia lymphoma is caused by a mutation in a pre-B cell in the marrow. That's where B cells are born. T-cell acute lymphoid leukemia lymphoma is caused by a mutated pre-T cell in the thymus, where T cells mature. In the acute lymphoid leukemia lymphomas, the characteristic progenitor cell is the lymphoblast. They're large-ish with purplish nuclei. No granules and no hour rods. That's AML. They are PAS positive though, if that helps, as well as TDT positive. If it's a T-cell derived neoplasm, look for CD markers that are less than 10. If it's B-cell derived, look for CD markers 10 and higher. Mutated B lymphoblasts like to cause the leukemic form of disease. That means over 25% of the marrow is involved, causing neoplastic cells to fill the circulation. Remember, you may have a high white count, but those are just all those blasts. With extensive bone marrow invasion, your patient will likely suffer from a functional pancytopenia, as more lymphatic organs get taken over. Look for hepatosplenomegaly and lymphadenopathy as well. Maybe some bone pain. Mutated T-cell lymphoblasts like to form lymphomas rather than leukemias. That means a mass outside the marrow. You might even find a mediastinal mass. Compare all this with the chronic version, CLL. It's slow, it's indolent. ALL was in kids, while CLL commonly affects patients over 60. CLL is caused by a mutated B cell in the bone marrow. This time it's more mature. Look for mature cell markers like CD19, 20, and 23. CD5 too, which is weird. Mature monoclonal B cells start to take over the marrow and leak out into the serum, usually causing a white count above 5,000. On the smear, look for smudge cells and lots of mature B lymphocytes. And it's not just the blood. CLL takes over the lymphatic tissues, leading to lymphadenopathy and hepatosplenomegaly. CLL cells don't work very well, and they even inhibit any normal B cells that are still around. This can manifest as hypogammaglobulinemia, a lack of antibodies, in other words. Or B cells can start producing autoantibodies, which can take down various cell lines. And don't forget about hairy. Hairy cell is, well, hairy, of course, but it's also TRAP positive and likes to take over the bone marrow and cause myelofibrosis. Well, after talking about it so much, winter is finally here. That wasn't unnecessarily drawn out or anything. Some of those middle parts especially. Could have done without those. It's a bit nippy out here. So let's head inside, shall we? If the whole EMEA versus OMA thing wasn't already confusing enough, get excited for some more OMAs. Oh man, glad we're not in that owlery anymore. Way too much creepy owl-like contact. Haunt my dreams. Well, now that we've learned all about Hodgkin lymphoma and those owl-eyed Reed-Sternberg cells, let's move on to the lymphomas that don't have owl eyes, otherwise known as the non-Hodgkin lymphomas. And you're in for a treat. let's continue our journey through the lymphoid neoplasms, cancers derived from the B and T cell lineage. In our last sketch, we met the leukemias, and now we're moving on to the lymphomas. Let me explain. If the neoplastic cells take over the bone marrow, subsequently causing cells to leak out into the bloodstream, that's a leukemia. We saw this in the last sketch, with acute B and T cell lymphoblastic leukemia, chronic lymphoblastic leukemia, and hairy cell leukemia. It's all about getting into that bone marrow. It's just what they crave. Lymphomas, on the other hand, such as Hodgkin and non-Hodgkin, originate in the lymphatic system, lymph nodes, and look like lymphoma, while lymphomas can take over the bone marrow and present like leukemias. So the best you can do is take a look from whence it came. And on that note, welcome to Hogwarts School of Wizardcraft and Witchery. This hidden Scottish castle houses one of the world's oldest schools for magic. Wizards and witches arrive by train, eager to learn from the finest faculty in the world. Students have an opportunity to master everything from potions to spells, while bonding with friends over a game of chess or a trip to the Owlery to write home. You know what else?